Hi everybody, my name is Adam Sheikali and I am a second-year medical student at the Medical College of Wisconsin. My project is multi-institutional study of pediatric renal trauma. It was conducted within the Department of Surgery at the Medical College of Wisconsin in Milwaukee. So just some background, children are at increased risk for renal injury compared to adults. However, we seem to manage pediatric renal traumas by the collective experience of adult renal traumas. So this study is hoping that we will be able to conduct a multi-institutional case series of pediatric renal traumas, which will allow us to redefine the guidelines in treating these injuries while simultaneously identifying gaps in knowledge. The specific aims of this study are to hopefully determine the variability of pediatric renal trauma management in the United States between different centers. So this study is looking at around 15 universities and institutions across the country, and hoping that we'll be able to congregate a large amount of data that will hopefully allow us to redefine these management practices. Also, we are hoping to look and describe the preferred diagnostic modality for renal injuries, which will allow us to further identify the primary reasons for needing certain interventions, especially in low-grade renal injuries, which would be anything considered a 1, 2, or 3 renal injury, with 4 and 5 grade renal injuries being the highest, most severe, and typically involving injury to the urinary collecting system. Lastly, we also would like to see whether or not aggressive urologic intervention or just simple hemodynamic monitoring is the better modality in order to treat these renal injuries and hopefully reduce morbidity of the patients that we see. The methods were pretty standard. It was a retrospective chart review that included the last 10 years, so from 2010 to 2020. Patients, like I said, were gathered from 15 universities across the country, with the University of Washington being the parent institution. We looked at baseline patient demographics, injury characteristics, in-hospital clinical data, including acute treatments, radiological reports, and available follow-up post-discharge data in order to see whether or not long-term sequelae occurred, which is another variable in which we are looking at. We also are looking at radiologic images used to characterize the patient's renal injuries, most specifically the initial imaging done and then the follow-up that was done within 24 to 48 hours. This is where we currently are in our project. We unfortunately do not have all of our data in at the moment, but we're hoping that by the end of 2021, we will have all of radiologic images de-identified across all the institutions in the country, and that's when we'll really be able to buckle down and do more intricate data analysis and make some connections. We are hoping as well to use descriptive statistics to summarize institution and patient characteristics as well as clinical and radiological variables, and then eventually make a multivariable logistic regression model that will more accurately depict our data and our findings. As I mentioned, although we do not have results at the moment, I did include some figures that hopefully would give some insight into the patients at MCW and what we are looking at right now. So figure 1 is a distribution of the graded renal injuries among patients at MCW, and as you can see, grade 3 injuries are the most common, with grade 1, 2, and 4 all being equal with around 22 patients. And although we do not see many grade 5 injuries, they still are prevalent, and so we have some as well. Additionally, figure 2 shows the modality of initial diagnosis of renal injuries for patients admitted to Children's. And as you can see, the most common initial imaging modality is a CT with contrast and delays. These delays are really important in order to see whether or not there's injury to the urinary collecting system. We are hoping that our results will illustrate that pediatric renal traumas do require different management practices, and those management practices being less operative. And we also hoped and expect to see that most initial imaging modalities are CTs with delays. Our conclusions go hand in hand with our results. As I said, we do expect to include that pediatric injuries do require different management practices than those of adult renal injuries, aka more conservative / less invasive practices, and this would allow us to hopefully redefine the way in which we do treat these injuries. We also have large reason to believe that over-triage of patients can be largely reduced based on initial imaging and whether this imaging includes delays. For example, if a patient comes in with a renal injury that is grade 1 or 2 and we do not believe that they need to be operated on, there's no reason for them to be admitted. Bed rest would suffice. The next steps of this project are to hopefully publish and implement our findings so that other clinicians can find better ways to manage their practices, and hopefully this collective study will allow us to identify further gaps in knowledge as well. The references are below, and I would like to acknowledge Dr. Catherine O'Brien, Dr. David Gourlay, Marjorie Bissett Baker, Melissa Lenogo for all your help thus far. It could not have been done without you. Thank you so much.